Look, for many of us, we see 17% of the U.S. economy is now in the tax-exempt space. For that, we're supposed to actually see what is the value of the community good. Help us understand the value of the community good and how we're doing it well. Ms. Will.
Thank you so much, Mr. Chairman. I want to thank our witnesses for being here today. You know, our nation's nonprofit hospitals are the cornerstone of our health system, providing vital care to millions of Americans. These hospitals deliver unmatched benefits to our communities, keeping Americans healthy, bearing the brunt of care to those in need, and serving as a major employer in many of the areas in which they reside. Collectively, they deliver more in community benefit and charity care to their communities than the foregone revenue from their federal tax exemption. Yet nonprofit hospitals and our health systems are under attack. They are holding, I believe that this hearing today is a little more of a distraction than it is about the actual subject. Unemployment is on the rise, costs at the grocery store are surging, and healthcare premiums are set to skyrocket, all thanks to this administration. In the big ugly bill, Republicans made a deliberate choice to strip away more than 15 million Americans of their health care and hit countless more with increased costs and red tape while giving billions to billionaires. Their refusal to extend the enhanced tax credits that help so many working Americans purchase their health coverage means another 4.2 million will become uninsured, and tens of millions will see their largest premium hike in 15 years. Republicans enacted a $1.5 trillion in health care cuts, which are falling at the expense of our hospitals, providers, and patients, all to pay for tax cuts for billionaires. In Alabama, 375,000 people purchasing their own health insurance receive tax credits to help afford coverage. If billionaires could get tax cuts, then why not working Americans? If Republicans continue to refuse to extend these tax credits, 100,000 more Alabamians will lose their health care. A 60-year-old couple in my district earning just over $80,000 will see their costs skyrocket more than 300% by about $20,000. They would have to spend 32% of their income on the health insurance alone. Republicans have dramatically cut our health system, and they are trying to hide from their record and distract the American public. Nonprofit hospitals have a long history of operating at a low financial margin. In fact, the ordinary nonprofit hospital typically operates at a negative operating margin in most years. They also are more likely than for-profit or government hospitals to offer every type of medical service. And nonprofit hospitals are considerably more likely to provide poorly reimbursed and thus unprofitable services. These services are disproportionately needed by patients who are uninsured or underinsured. The bottom line is that without nonprofit hospitals, we will continue to see increased rates of chronic diseases, decreased access to emergency care, and an increase in premature deaths. With current attack on hospital stability through Medicaid cuts and our failure of this committee to protect access to care, we must protect our hospitals to ensure access to care and the improvement in the quality of life for all of our constituents. I'm looking forward to today's hearing, Mr. Chairman, and look forward to the testimony of our witnesses, and I really hope that we all can come to a consensus that supporting our health system instead of attacking it is what we should be doing. I yield back the balance of my time.
Now, introduction of our witnesses. William Hyde is Executive Director of Consumer Research. It doesn't actually say for who. Dr. Stanley Gottfried is Chairman of the Board of Do No Harm. Dr. G. Bai is Professor of Health Policy and Manager at Johns Hopkins Bloomberg School of Public Health. Christopher Wally is Associate Director of the Center of Advancing Health Policy through Research at Brown University. Dr. Jill Hurwitz is a Tolman Family Innovation Professor at Northwestern University, Pritzker School of Law, and a Professor of Emergency Medicine at Feinberg School of Medicine. William, you're up first.
Chairman Schweikert, Ranking Member Sewell, members of the subcommittee, good afternoon. My name is William Hild, and I'm the Executive Director of Consumers Research. Our mission at Consumers Research is simple: to increase knowledge and understanding of issues impacting consumers and to ensure their freedom to act on that knowledge. So I appreciate the opportunity to testify today as part of our continued public education campaign. This year, we expanded our consumer education initiatives to include nonprofit health systems nationwide that leverage numerous funding streams from the federal government and benefits from tax-exempt status to advance controversial political and social causes rather than serve their communities. And often, the advancement of political agendas such as DEI, gender ideology, and climate activism is easier to find on their public-facing web pages and materials than actual prices for their services. As part of our efforts to educate consumers, we issued a consumer warning detailing how several large tax-exempt health systems have devoted critical resources to infuse everyday operations with progressive ideological goals. These initiatives include instituting large-scale DEI bureaucracies, promoting gender ideology to children, and supporting environmental activism. At the same time, hospitals are pushing political agendas. Many fail to comply with healthcare price transparency rules and proportional growth in charity care. This misprioritization of politics over patients distracts hospitals from their core mission and can compromise the quality of treatment and increase costs, which can put consumers in serious physical and financial danger. Let me put this in perspective. Under Section 501c3 of the Affordable Care Act's added 501r obligations, charitable hospitals are supposed to operate for public, not private interests. The community benefit standard was intended to ensure that in exchange for tax privileges, hospitals would provide measurable benefits: affordable care, financial help, and improved services. Nowhere in federal law are discriminatory programs, the mutilation of minors, or investment in green boondoggles required. Through our research into hospital programs, public-facing materials, and leadership statements, we documented cases where major nonprofit health systems, such as Cleveland Clinic, Vanderbilt University Medical Center, Henry Ford Health, Memorial Hermann Health Systems, and others, funneled resources into DEI, promoted environmental activism, and performed gender mutilation procedures on children. The deliberate choice these health systems are making to prioritize political activism are concerning and costly. They require staff, program budgets, marketing, and other resources. Every dollar placed into a DEI policy is a dollar not placed into price transparency. Every dollar used for gender ideology is a dollar taken from charity care. Every dollar put towards environmental activism takes money away from staffing or capacity expansion. Are hospitals counting these programs as meeting the community benefit? Without clear and verifiable reporting, neither Congress nor taxpayers can answer that question. Tax-exempt status and access to federal funding, grants, and savings programs are public privileges. Congress has broad authority to condition those privileges on transparency and patient benefit without dictating medical judgment. Improving outcomes for patients is a worthy goal, and many hospitals do important work in this area. The oversight problem comes when community benefit is used as a vague justification for engaging in partisan political activity. Congress could require line item disclosure and outcome measures for any equity spending that is claimed as community benefit. Initiatives should focus on quality of care and patient outcomes, and hospitals should show the data. Hospitals are civic institutions that hold public trust. Nonprofit hospitals receive generous privileges because Congress expects them to deliver measurable community benefits. When systems elevate discriminatory policies, activist climate campaigns, or allow gender mutilation of children, this trust fails. Congress can restore this trust through more precise definitions, verifiable reporting, and alignment of privileges with the value patients receive. Thank you for the opportunity to testify. I welcome questions.
Chairman Schweikert, Ranking Member Sewell, and members of the committee. Thank you for the opportunity to testify today. My name is Dr. Stanley Goldfarb, and I serve as the chairman of Do No Harm, an organization of over 35,000 medical professionals and concerned citizens devoted to defending the timeless standards of medical excellence and keeping divisive identity politics out of the practice of medicine. Nonprofit hospitals enjoy extraordinary privileges under federal law, most notably their tax-exempt status. This taxpayer subsidy, worth billions of dollars each year, is designed to enable hospitals to provide care to the underserved in their communities. But instead of focusing only on curing disease, expanding access to care, and saving lives, too many are also focused on controversial and counterproductive political causes, such as diversity, equity, and inclusion, or DEI, and radical gender ideology that includes dangerous interventions on children. These practices are misguided. The problem is clear. We are witnessing hospitals that should be committed only to serving the sick, diverting their attention to political activism. They are spending millions on DEI bureaucracies and radical ideology interventions when these resources could be put to far better use. They are spending valuable time and organizational resources on these issues. This is a profound betrayal of the public mission. It is also at odds with the national priorities recently established through a series of executive orders issued earlier this year. Yet many nonprofit hospitals have been and continue to act in direct opposition to those priorities. The evidence is clear. At Massachusetts General Hospital, administrators announced in April 2024 that they would scale back child neglect and abuse reports from mothers who test positive for drugs because they feared that mandatory reporting was perpetuating what they called, quote, structural racism, end quotes. Duke University Health System, which received over $1 billion in federal funding in fiscal year 2023 alone, was the subject of federal rights complaint in March of this year for implementing race-based preferences in hiring and medical school admissions, while promoting the notion that white males are, quotes, agents of oppression. Corewell Health in Michigan required every employee to sign a pledge in support of DEI or risk termination. Just 2 years ago, the Mayo Clinic pledged $100 million for indoctrination sessions about microaggressions and eliminating systemic biases and the supposed dangers of colorblindness and meritocracy. Similar DEI pledges, training mandates, and equity bureaucracies exist at Memorial Health in Illinois, Baton Rouge General Hospital, Maine Health, Kaiser Permanente, and Providence Health System, just to name a few. This politically charged approach to healthcare management is built on the false premise that our medical institutions are mired in bigotry. America's doctors, nurses, and other healthcare professionals are not racist, sexist, or homophobic. Rather, they work tirelessly every day out of love for the common humanity they see in all their patients. Radical ideology in our healthcare system is also seriously affecting our most precious patients, America's children. Between 2019 and 2023, nearly 14,000 minors underwent some form of medical intervention marketed as so-called gender-affirming care, including puberty blockers, cross-sex hormones, and more than 5,700 irreversible sex change surgeries. Many of the hospitals most deeply involved are nonprofits, including Boston Children's Hospital, the Children's Hospital of Philadelphia, Seattle Children's, Children's Minnesota, and Children's Hospital in Los Angeles. While all of this has been happening in our country, other nations have been rapidly rolling back those policies. The United Kingdom, Sweden, Finland, and others have taken significant steps to protect children and close this dark chapter of medical history. Chairman Schweikert, Ranking Member Sewell, and members of the committee, your leadership on this issue is vital. By exposing these abuses and demanding change, you are defending both taxpayers and patients. The American people should not be compelled to subsidize ideological agendas in the name of health care. It is time to restore tax-exempt hospitals to their proper mission, serving the sick, healing the injured, and advancing medicine free from politics. Thank you very much.
Mr. Chairman, Madam Ranking Member, and members of the subcommittee, thank you for the honor to testify. I'm an accounting and health policy professor. My views do not represent Johns Hopkins or any of its affiliations. Nonprofit hospitals have a contract with taxpayers. They're expected to advance charitable mission for the community. In return, taxpayers grant them tax-exempt status. Income, property, sales tax, all exempted. Our study, published in JAMA, shows total tax benefits reached $37.4 billion in 2021. More than half was state and local. Money borrowed at low interest rates allow hospitals to buy real estate tax-free and invest without paying tax on the return. Our new tax notes study shows nonprofit hospitals held nearly $500 billion on investment assets, issued $180 billion in tax-exempt bonds. So in total, generated nearly $10 billion in tax arbitrage profit. This is just in 2022. They may also access the lucrative 340B drug pricing program. Our health affairs study found many urban nonprofit hospitals have dual classified themselves as rural to qualify for rural-only perks, such as 340B eligibility. In 2023, 3/4 of urban hospitals classified as rural were nonprofits, including large academic medical centers, such as New York Presbyterian and Cleveland Clinic. Then what charitable activities do these nonprofit hospitals do? The ACA introduced community benefit reporting on IRS Form 990, including 8 categories. The category that best represents whether a nonprofit hospital advances the charitable mission is charity care. Most other categories aren't comparable across hospitals. Rich ones can hire consultants to package marketing and other expenses peripheral to patient care as community benefit. But the charity care is dollar-for-dollar service provided to the disadvantaged. Our health affairs study shows nonprofit hospitals give less charity care as a share of expense than for-profit hospitals. Even Medicaid shortfall, which also counted as community benefit, our JAMA Network Open study finds nonprofits provided no more than for-profits. Today, nonprofit hospitals really act like for-profits. Financial and real estate investment, aggressive debt collection, anti-competitive contracting, etc. But the tax-exempt status was granted to them based on the situation more than a century ago, when hospitals were solely staffed by volunteers to care for the poor. It does not reflect today's situation and gives nonprofits an advantage that fuels consolidation in the hospital market. Then what should the Congress do? Just counting dollars and mandating a federal number won't work, because large hospitals will exploit bright line rules and situations vary very widely across hospitals and communities. Congress should require hospitals to disclose property tax savings, sales tax savings on the IRS Form 990. These numbers are straightforward to estimate, so local community can grasp what's on the line, and local governments can tailor their policies. Congress can also impose excise tax on hospital financial investments and real estate holdings, the same way as Congress taxes university endowments. Also, close the rural-urban dual classification loophole that allow urban hospitals access the 340B program and other rural-only perks. In the long run, if Congress truly wants hospitals to best serve the community, competition is the key. Remove anti-competitive rules, level the playing field, open the market, and let nonprofit hospitals compete on equal footing with for-profits, physician-owned hospitals, physician practices, and other facilities. Also, move from subsidizing hospitals to funding patients to truly empower patients. Once there's a competitive, patient-centered market, everyone, including nonprofit hospitals, will have to do the right thing for patients in order to stay in business, rather than simply focusing compliance with top-down rules. With technology advancement, competition sparks innovation, slashes prices, raises quality, and patients will get real affordability and access. That becomes the true community benefit for the American people. Thank you very much.
Chairman Schweikert, Ranking Member Sewell, and members and members of the committee, thank you for the opportunity to testify today. My name is Christopher Whaley. I'm a health economist and an associate professor of health policy at the Brown University School of Public Health. The focus of my remarks today is about the U.S. hospital industry, and in particular, nonprofit hospitals. I first want to acknowledge the importance of access to high-quality and affordable health care for all Americans and the important role hospitals play. Hospitals deliver life-saving care that makes us all healthier and improves our well-being. Hospitals are also a key source of employment. The U.S. hospital sector is among the largest in the economy and alone accounts for over $1.5 trillion in economic activity. Hospital markets in the United States have two key distinct features. First, the U.S. healthcare or hospital sector has experienced decades of unchecked consolidation. Nearly all U.S. hospital markets lack sufficient competition. As a result, the prices that hospitals charge the 160 million Americans with employer-sponsored insurance are high and variable and have little to no link to quality and are not explained by cost shifting. Hospitals currently charge patients prices that average 250% of what Medicare pays. Rising hospital prices do not improve quality and strain affordability for patients, employers, and taxpayers. Second, over half of U.S. hospitals are nonprofit. While nonprofit hospitals play a critical role in providing patient care and employment to healthcare professionals, the total financial value of nonprofit tax exemptions exceed $37 billion per year. In return for tax exemption, the IRS requires that nonprofit hospitals be organized and operated with the purpose of primarily benefiting the community. Yet, this does not always appear to be the case. While hospitals do provide community benefit spendings, some estimates value the tax exemption exceeds community benefit spending by over $25 billion per year. This discrepancy has led to bipartisan efforts to increase oversight of tax-exempt hospitals and to further regulate their financial assistance and debt collection practices. As I highlight in my written testimony, tax-exempt hospitals charge prices, provide levels of care quality and charity care that are similar to for-profit hospitals. Yet, the substantial financial advantage of tax-exempt hospitals has led to concerns that quality should actually be higher. If community investment is not larger and quality is not superior, then where are the extra dollars from these financial advantages going? As I again detail in my written testimony, I am concerned that the financial resources may be used in ways that do not directly improve patient care, including increased executive compensation, investment vehicles and account, which collectively exceed $1.5 trillion in value, and marketing, including sponsoring stadiums and sports teams. Tax-exempt hospitals also have access to the 340B discount program. My research finds that 340B savings are not passed along to patients. My research with Dr. Bai also finds that many nonprofit hospitals duly classify as both rural and urban hospitals, double dipping to receive the benefits of both, and directing limited resources away from rural hospitals. To address these concerns, Congress could consider several policy reforms. First, high and rapidly rising prices, which differ enormously from one hospital to another, but not related to quality or cost, combined with substantial investment accounts, may create the perception that some tax-exempt hospitals are operating with a profit motive. To ensure that tax-exempt hospitals fulfill their charitable mission, Congress could define standards for financial assistance and benefits to the community health sector. Second, to more broadly ensure that U.S. healthcare markets deliver high-quality and affordable care, Congress and federal regulators could consider policies that prevent harmful consolidation in both the provider and insurance systems. This includes strengthening antitrust scrutiny, expanding site-neutral payment policies, and banning anti-competitive contract terms. States as diverse as Indiana and Vermont have elected to directly limit hospital prices. Third, to address concerns that 340 rebate dollars are not directly benefiting patients, Congress could ensure that improved transparency on each hospital's 340B benefit, narrow 340B eligibility, or extend 340B discounts directly to patients to improve their ability to access affordable care. Finally, Congress can also consider codifying and standardizing existing price transparency policies and ensure that hospitals report required rates accurately and in a timely manner. In conclusion, Congress can help ensure that the substantial tax benefits nonprofit hospitals receive translate into tangible improvements for patients and communities. Thank you, and I look forward to answering your questions.
Chairman Schweikert, Ranking Member Sewell, and members of the committee, thank you for inviting me to today's hearing. My name is Jill Horwitz, and I'm the Trobman Family Innovation Professor of Law and Professor of Emergency Medicine at Northwestern University, although the views I express today are entirely my own. My research concerns health policy and nonprofit law, and I've been studying nonprofit hospitals for almost 30 years. In my testimony today, I will discuss the significance of nonprofit ownership for medical care and the very important related tax exemptions. Since I first began researching hospital behavior, the distinct importance of nonprofit hospitals has only grown. In my brief time, I'll focus on 3 reasons why that's the case. First, nonprofit hospitals are simply the backbone of the American hospital system. More than half of all hospitals in the United States are nonprofit, and almost 70% of admissions to acute care hospitals are to a nonprofit hospital. Nonprofits are even more important for rural health, and they account for almost 3/4 of all the teaching hospitals in this country. Yet the vast majority of nonprofits are not moneymakers. In fact, unlike for-profits, the ordinary nonprofit hospital typically operates at a negative operating margin. So even with the benefit of tax exemption, nonprofits tend to be under financial stress. Things are likely to get worse given Medicaid cuts, declines in employer-sponsored insurance, and potential loss of Medicaid subsidies, marketplace subsidies. Given these facts, it's simply not possible for nonprofit hospitals to cover the rising costs of providing health care to the uninsured and underinsured in America. Second, nonprofits are critical because of the services they provide. Because nonprofits tend to be larger than other hospital types, they are more likely to offer every major type of medical service than for-profits are. And even accounting for the fact that nonprofits tend to be larger than for-profit hospitals, nonprofits are critical because they offer different types of services. In several studies, based on decades of data, my research has demonstrated that nonprofits are less likely than for-profits to choose the services they offer based on the profitability of those services. Comparing similar nonprofit and for-profit hospitals, for example, those that are of the same size, serving similar populations, nonprofits are more than 6 percentage points more likely than for-profits to offer pretty unprofitable services. Obstetrics, psychiatric care are a couple examples. Yet there are over 4 percentage points less likely than similar for-profits to offer profitable services like invasive cardiac care. Some of these services tend to be very expensive and often overused. They prioritize medical services that are important to all Americans. Ownership not only affects the behavior of individual hospitals, but there are also spillover effects. The more for-profits in an area, the fewer unprofitable, and the more profitable services all the hospitals in that area provide. In short, nonprofits do not act like for-profits where it counts, the provision of medical care. Finally, if nonprofit hospitals find themselves under more financial pressure than they already face and are forced to sell their assets and operations, the for-profit buyers are likely to be private equity groups. These groups are much more aggressive at seeking profits than the previous forms of for-profit hospitals that I have studied. Recent research shows that private equity owners tend to reduce competition, a problem that Professor Whaley just highlighted. They raise prices, they increase financial instability, and they have worse patient outcomes than other hospitals. In one recent example, Steward Healthcare, which owned 31 hospitals with 3,600 beds across 8 states, it went bankrupt. It endangered patients and in the end left many communities without care. The American healthcare system is facing great challenges. Needs will continue to grow given the aging population, predicted rising levels of uninsurance, and healthcare expenses, projected declines in employment, and other factors. Nonprofit hospitals provide vital and sustainable services in communities, and the services they provide are more likely than for-profits to meet important social needs. In today's market and demographic environment, policymakers ought to focus on ways to strengthen and not weaken nonprofits in the American hospital system. Thank you for considering my views.
Thank you, Doctor. And as my tradition is, I will go last in regards to questions, so I'm going to ask the chairman of the full committee to begin.
Thank you, Chairman Schweikert. Since 2014, 12 hospitals have closed in Missouri, 5 in my congressional district alone. Folks living in the communities I represent, they're forced to drive up to 2 hours for basic care, and in the southeastern part of Missouri, otherwise known as the Boot Hill, has not had access to maternity care since 2018. This is absolutely unacceptable, but our story is not unique. As patient volumes decrease and paperwork burdens increase from government and Medicare Advantage prior authorization requirements, many independent rural hospitals are overwhelmed to the point of closure unless they are purchased by large nonprofit systems that make enough money in urban areas to afford losses in rural areas. Dr. Whaley, given the healthcare and economic challenges faced in rural areas, what can we do to help fortify rural hospitals so that consolidation becomes a business decision rather than a sole lifeline for the preservation of access to care? And how can we better align reimbursement incentives so that rather than merely throwing money at this problem, we can create an environment in which rural hospitals can thrive?
Thank you for your question, and I certainly agree that rural hospital markets certainly need focused attention and are critical for rural communities. One thing that our research has highlighted is how competitive imbalances often disfavor rural safety net and critical access providers. If you are a hospital that in some sense is left out of consolidation and don't have the market clout of your neighboring competitor that has consolidated, in many cases you are left with more Medicaid patients, more uninsured patients that the consolidated systems nearby refuse to take. I think that improving competition in healthcare markets can be something that uniquely helps support not just critical access in rural communities and hospitals, but hospitals across the board. In addition, work with Dr. Bai has highlighted how many of the financial assistance programs designed to support safety net in rural hospitals, in some cases, have been taken advantage of by hospitals that are not geographically rural. I think closing some of those loopholes can make sure that existing resources are directed to the intended rural hospitals.
Perfect. According to recent reporting, there are a growing number of urban hospitals, just like what you said, that's masquerading as rural facilities in order to get even more generous benefits under the Medicare and the 340B drug program. Benefits that are supposed to go to truly rural hospitals. According to a study published by Health Affairs by two of our witnesses here today, Dr. Bai and Dr. Whaley, over 3/4 of the so-called duly classified hospitals are nonprofits operating in urban communities. Dr. Bai, is it merely a coincidence that so many of these urban hospitals that are exploiting a loophole to gain access to benefits meant for rural communities are the same facilities that are pulling in generous benefits as tax-exempt organizations? Or is it safe to say there is a link and sense of entitlement among the leadership of the facilities?
I think the regulatory loopholes put the money on the table that these hospitals cannot resist. If Congress does not act, probably very soon the majority of nonprofit urban hospitals will become duly classified in order to access those rural-only perks. So these hospitals, they are all work in their incentive structure, and they are going to behave according to what the incentive guides them to. And this is, to me, more like a policy failure, and it creates eventually a market distortion.
So the generous benefits bestowed on tax-exempt hospitals come with an obligation on their part to provide charitable benefits to their communities. Yet we have data showing that from 2020 to 2022, over half of such hospitals got more in tax benefits than they invested in their community. In 2020 alone, the tax-exempt benefit was worth an estimated $28 billion, while the amount spent on charity care totaled over $10 billion less. So, Mr. Hild, what sort of excuses do these tax-exempt hospitals make to justify the massive deficit between the charity care they provide and the tax benefits that they receive? And how has this imbalance been able to grow so substantially in recent years? And what should be done to flip the equation here?
Yes, member, thank you for that question. What I would say is one of the reasons that this imbalance has grown so much is that increasingly hospitals don't see themselves as just healthcare providers or even as hospitals. In the report that we put out, one of the common themes across all of the executive C-suites of these hospitals was saying that they only saw healthcare as part of their mission or highlighting other things that they thought were core to their mission that a reasonable person would not consider part of providing health care. So I think the mission creep of a lot of these hospitals getting into real estate investment, getting into DEI, getting into political activism, naming stadiums, this shows a lack of discipline in making sure that they stay within the healthcare provision. I think that leads to all these other things. Just like you would want to make sure that if you would want your oncologist to be a specialist, correct? You want your hospital to be a specialist. You do not want a generalist hospital, and I think that's part of the issue is you have a massive mission creep. I think in terms of solutions, one thing we should be looking for is for Congress to act to make hospitals be more explicit and detailed in the community benefits that they're providing so that taxpayers can know that they're actually providing health care and not off on boondoggles.
Thank you. I yield back.
The chair. Why is it not working? The chair now recognizes the ranking member, the gentlelady from Alabama, for 5 minutes.
Thank you. I want to thank all of our witnesses. I am highly concerned about healthcare delivery in my district. In fact, I grew up in this district. It's a rural district. People know it because my hometown, Selma, was known for voting rights. But the reality is it's a town of 19,000, and we are lucky and blessed to have a hospital. But we service a lot of the rural communities right around it. And it's disturbing to me that we're, instead of expanding and creating avenues to health care, today we're really focused, at least this hearing is, on ways to harm my constituents who rely on services from these nonprofit hospitals. In my district, a number of the rural hospitals with nonprofit tax-exempt status are on the verge of closing. Since 2011, 16 hospitals across my state, Alabama, have closed. The very existence of rural hospitals is an immense community benefit. They are often the only source of medical care in their area, and they provide essential services like emergency care, screenings, and transportation. They are also major employers in the rural communities that I represent. Dr. Horowitz, can you explain how tax-exempt status allows these hospitals to continue playing a critical role in the communities they serve?
Yes, the very existence of a hospital in a rural area can be thought of as a community benefit. Without nonprofit hospitals, many rural regions simply would have no hospitals at all. This is exactly what Representative Smith just explained, right? The more rural an area, the less likely there is to be a for-profit hospital. And as you get more rural, even the nonprofit hospitals can't afford to exist in those areas. So they're predominantly government hospitals if they exist at all. So
I would assume states like mine that didn't expand Medicaid, the financial pressure is even more mounting.
Right. I think the financial pressure under the best of circumstances is very difficult in a rural area, and when you have decreases in Medicaid, it gets worse and worse. And so competition can't solve this problem because it's not economically possible to exist without subsidies.
Yep. Hospitals in my district have been committed to providing care for my constituents despite Alabama's failure to expand Medicaid. Our hospitals have also endured receiving the lowest Medicare reimbursement rates in the country due to the unjust wage index. But those of us from small rural communities and small red states know that. Listen, I think that the reimbursement rate in this country due to the unjust wage index is abhorrent, but it's not going to change because we have winners and losers, and the states that are slightly bigger are the winners. With pending Medicaid cuts and talks of attacking nonprofit tax-exempt status, I'm simply burdened with the thoughts of the impact on the hospitals in my district. Dr. Horwitz, has Medicaid expansion impacted the amount of community benefit hospitals provide, and if so, why?
Medicaid expansion allows hospitals to treat more people. If hospitals need to take patients who can't afford to pay for their care, they're going to have to find the money somewhere. So I will tell you, when I was growing up, we had this saying in my house, which was, there's no money tree in the basement, right? Nonprofit hospitals don't have a money tree in the basement. They have to make their money somewhere. It has to come from reimbursement, or it has to come from profits from offering profitable services, often services that are overprovided and are very expensive for the federal government, like cardiac care paid for by Medicare, or they have to cut unprofitable services. And so if they have to do that, what they're going to do is cut services like psychiatric care, like drug abuse treatment, which is desperately needed in places with the opioid problems.
Yep. So I think that this will only be exacerbated, it sounds to me, by the big ugly bill, because it's going to cut Medicaid. So I would think that this would only compound the problem. Can you speak about that with my last remaining seconds?
Yes, by reducing Medicaid coverage, by reducing levels of insurance. If people lose their jobs and they cut employer-sponsored insurance, we're going to have worse and worse problems with uninsured Americans.
Thank you. I yield back.
Thank you very much. The chair now recognizes herself for 5 minutes. This hearing continues an important conversation that we began 2 years ago about ensuring access to quality care for all Americans and making sure that patients have fair and workable options to get the care that they need. At our previous meeting, I raised concerns about the guidelines the IRS uses to determine the nonprofit status of a hospital. And unfortunately, not much has changed. Patients with financial insecurity are still being asked to jump through extensive hoops, providing bank statements, loan records, detailed household budgets on short notice, just to find out if they qualify for financial aid. At the same time, these nonprofit hospitals continue to face only vague and limited requirements from the IRS to maintain their privileged tax status. And that imbalance, and I think my Democrat colleagues would agree with me, that imbalance remains troubling. And if anything, the stories and reporting that we've seen since this have underscored how this system too often favors large institutions at the expense of patients. We have heard a lot of stories today about how these healthcare systems are actually wasting money on Super Bowl ads, on stadium naming, on exorbitant pay for executives. I think we would all like to see those dollars being spent on patients, on making sure that healthcare dollars are actually being used for healthcare. We've seen that it's been abused. So, Dr. Goldfarb, the community benefit standard is an important piece in determining whether a hospital qualifies for nonprofit status. It requires hospitals to demonstrate that they provide benefits to the broader community and operate to serve a public rather than a private interest. However, in recent years, the standard has come under scrutiny, and with critics arguing that it is too vaguely defined and too easily met by certain hospitals. So is this true? And if so, how are the nonprofit hospitals taking advantage of the vague language in the statute?
Well, thank you very much for that question. You know, I'm a clinical doctor. I was a nephrologist for 40 years. So I really bow in front of the expertise of all these individuals here who are expert economists. But I would say that this idea of exactly what's a community benefit is very vague, and our organization has looked into this and have tutored me on this issue very well. I think the point is that hospitals really need to think very hard about the things that they waste their money on. And our point of view is that creating these DEI enterprises has been a huge problem. So let me just read a brief excerpt from a testimony by a nurse at the Mayo Clinic. I participated in an event. It was a 2-day event in early August, Mayo's 2-day Rise for Equity event, which offered in-person and virtual attendance for continuing education credit. It was designed for professionals, including many people in the hospital, administrators, doctors, hiring managers. The goal was to advance and direct policy programs and institutional initiatives across the medical landscape towards health equity. She said, I encountered nothing but indoctrination. I was told in no uncertain terms that racial and social...
I've got 3 more questions I've got to ask.
I'm
so
sorry,
I wanna
I'm
make sure.
almost, yeah, I'll finish and I'll make my point. Sorry, racial and social justice is a known public health threat. I learned tips for recognizing and addressing microaggressions. I was told systemic biases in physical space and that such ideas as meritocracy and colorblindness are myths. It's very hard to measure the impact of these kinds of activities on an organization, wasting time, wasting resources.
Thank you very much. Mr. Hill, should Congress think about ways to amend the community benefits standard? Why or why not?
Yes, they absolutely should. Taxpayers should know that there's accountability for this standard in return for the tax-exempt status, and that we can draw a direct line between what the hospital's doing and health outcomes. Having vague standards around activities that aren't tied to any actual outcomes and don't even require any specificity around the money spent, so there's no accountability, is a real problem.
Well, I appreciate that. Today's hearing, I think, underscores why this conversation actually matters. And the community benefit standard is supposed to ensure that hospitals truly serve the public and not just themselves. But when that standard is unclear, patients end up paying the price while hospitals enjoy tax privileges with limited accountability. It reminds us that when Congress delegates broad authority without sufficient oversight, agencies like the IRS can create policies that foster confusion, unfairness, and added bureaucracy in our healthcare system. Our responsibility now is to make sure that those standards are clear, enforceable, and truly aligned with the needs of patients and communities. I appreciate each and every one of you being here today, and I yield. The chair now recognizes Ms. Chu, the gentlelady from California, for 5 minutes.
Just 2 months ago, Donald Trump and Republicans rammed through their big, ugly law, the single largest attack on healthcare in our nation's history. It slashes $1.5 trillion from our healthcare system, including nearly $1 trillion from Medicaid and another $500 billion from Medicare. That means more than 15 million Americans are losing their health coverage, the greatest loss ever in our history. And it means premiums skyrocketing and hundreds of hospitals pushed to the brink of closure. This kind of financial pressure threatens the very hospitals that provide life-saving care and step up in times of crisis. In my district in the Pasadena area of California, after the Eaton fire destroyed more than 6,000 homes, Huntington Hospital transformed its auditorium into a skilled nursing facility for displaced seniors and open-day food pantry for families who lost everything. That kind of rapid response shows how essential nonprofit hospitals are to their communities and how much they rely on Medicaid dollars to stay afloat. In fact, the American Hospital Association reports that nonprofit hospitals provide a disproportionate share of unprofitable but essential services such as psychiatric emergency care, neonatal intensive care, burn units, and trauma centers. And in 2022, nonprofit hospitals provided an estimated $150 billion in total community benefits. In fact, nonprofit hospitals deliver approximately $10 in community benefits for every $1 received in federal tax exemption. So, Professor Horwitz, since most nonprofit hospitals already operate on razor-thin or even negative margins, how will Republican Medicaid cuts undermine nonprofit hospitals' ability to provide those community benefits and step up in moments of crisis, like what we experienced with the Eaton fire?
I think Medicaid cuts are going to make things a lot harder. So hospitals, as you point out, exist in very different communities with very different needs. And we don't want community activities, we don't want community benefits to look the same across all communities. There is no one size fits all. We need to have hospitals be able to respond to the next fire, the next pandemic, or whatever emergency we have coming down the pike. So in fact, the flexibility of nonprofit law recognizes this need, and it's why nonprofit law does not and never has required charities to have the single purpose of relieving poverty. Right? We need the YMCA, we need museums, we need universities. None of those are organized solely to relieve poverty. So what we should be focusing on is what nonprofits do best, which is provide medical care. They are more likely, comparing apples to apples, to have services that respond to these kinds of crises, like substance abuse treatment during the opioid crisis.
Furthermore, in the Big Ugly Bill, Republicans could have extended the Affordable Care Act premium tax credits that keep coverage affordable for 22 million Americans. But instead, they chose to let them expire. Now, on January 1st, premiums will skyrocket. Millions of people will be pushed off their coverage, and more patients will show up at hospitals uninsured. These patients will delay care until they're sicker and then flood emergency rooms, driving up costs for everybody else. So, Professor Horwitz, what does Republicans' deliberate choice to end these tax credits mean for hospitals already operating on thin margins?
I think the ending of the tax credits, the lowering of Medicaid coverage, the aging of the American population, and rising unemployment, and therefore the decline of employer-sponsored insurance, is going to put enormous pressure on the healthcare system, including hospitals, especially nonprofit hospitals, since they do tend to operate at lower operating margins. What this is going to mean is, to stay open, nonprofits are going to have to find money somewhere, and that somewhere has to come through their major service provisions. So they're going to have to offer more profitable services, again, raising prices and spending for the federal government, and doing care that may not be needed, or they're going to have to cut unprofitable care, and that means care like obstetric care, or care like even emergency room care, and we've seen this before.
Thank you. I yield back.
The chair now recognizes the gentlelady from New York, Ms. Maliotakis.
Thank you, Chairwoman. And the state of New York, which is where I come from, is different than the rest of the country in that all our hospitals are nonprofit due to state regulations. And specifically, in my district, we have 2 nonprofit hospitals that are also serve as teaching hospitals. These are on Staten Island, and then I have 1 freestanding emergency department in Brooklyn. And these hospitals do a great job of serving our community and training the next generation of doctors, of nurses, of healthcare workers throughout their teaching programs. And I greatly appreciate the work that they do there, and also in serving our community. In the last year, they served 1.5 million patients. They've treated almost 300,000 individuals in the emergency room. They've delivered 12,000 babies. And according to the 2023 990 tax forms filed by the hospitals in my district, they contributed over $300 million in community benefits, which included charity care costs, Medicare reimbursement shortfalls, health profession education funding, and reinvestments in the community. These reinvestments included free healthcare screenings, food insecurity programs, overdose prevention programs, and many other investments. But they also are considered major facility improvements and expansions projects to further meet the needs of a growing population, particularly in Staten Island, which is the only borough in New York City that does not have a public hospital. So my hospitals are taking on a higher rate of uncompensated care, and without their tax-exempt status, these reinvestment opportunities and community benefit contributions would not be possible. And so, at first I want to ask Dr. Bai, I agree that we must ensure that our nonprofit hospitals are effectively serving and that they're reinvesting in our communities in order to receive that tax-exempt status. And obviously the communities across the country, they face different challenges. And as I outlined, because we're the only public hospital, or the only hospital, we don't have a public hospital on Staten Island, I think our issues are unique. So my question is, how can we ensure that the nonprofit hospitals that are operating in good faith and spending their money effectively in the communities are not hurt by other requirements that could potentially hurt their one-size-fit-all approach to tax-exempt status?
So let's say we have a bright line regulation saying every hospital has to provide whatever percentage of the revenue in charity care. That will hurt hospitals struggling on the line. For example, if this year, without that requirement, the hospital could stay afloat, that hospital might be closer to bankruptcy.
Yes.
And second, if we have a bright line number, the number is always gameable, right? And then the large hospitals and politically connected hospitals will be able to do two things. One is to hire consultants to massage the number, try to look good, window dressing. Mm-hmm. Second would be to try to work with the regulatory process to change some little things in their favor. So that will create a very unfair environment for small ones. That's why whenever we see more detailed regulations, we see fewer and fewer small players, simply because the soil is toxic, they cannot survive.
Yeah. How can we improve oversight without overburdening the hospitals?
I believe
that's for you or Mr. Whaley, Dr. Whaley, whichever.
I believe competition would help force everyone to do the right thing.
So it sounds like your hospitals in your district are doing a strong job in fulfilling their community benefit. We know nationally that is not always the case, and so I think that there can be policies that go into place nationally, whether that is standardizing community benefit reporting, following some of the suggestions from the Government Accountability Office in a hearing before this committee 2 years ago, in ways to strengthen community benefit reporting.
Mm-hmm. I just want to make sure they're not going to be overburdened and dealing with more paperwork and more bureaucracy and red tape and some other things that could be hurdles and administratively. I think that's really important for us to consider as well. And one last question. On top of the community benefits that I've outlined, my hospitals, they provide 30,000 jobs in our community. And so they are the largest employer in my district. And Dr. Horwitz, how does the tax-exempt status allow for these hospitals to continue providing not only these key healthcare services, but the jobs for individuals that I represent?
So the national healthcare expenditures for 2024 aren't fully analyzed yet, but it looks like we've spent $5.3 trillion, or about 18% of GDP, on hospital care. So, take about 70% of that, maybe probably more for nonprofit hospitals. And you are, by simple math, looking at a lot of jobs, right? The nonprofit hospitals are a major employer in the United States, and if you put more financial stress on them through cutting Medicaid, through lowering rates of insurance, you are going to see some real cuts. Expired.
The chair now recognizes Mr. Delaney from the great state of Washington.
Thank you, Madam Chair. I want to thank all of our witnesses for being here with us today. We're discussing what my colleagues across the aisle are calling unfair tax practices at a time when the greatest transfer of wealth is occurring in our country. The Republican mega bill cut health care for over 15 million people across the country while handing a tax giveaway to billionaires. The Congressional Budget Office found that the effects of their law will result in working families paying more while the rich get richer. And this is in addition to several other ways Republicans are actively working to systematically dismantle our healthcare system. between cutting Medicaid, triggering over $500 billion in cuts to Medicare due to reckless spending, refusing to extend the Enhanced Affordable Care Act premium tax credits, firing our public servants who work on disease prevention, medical research, and solving future health crises, and slashing research dollars. This entire administration has been one broken promise to the American people, and definitely a broken promise on health care. And congressional Republicans have enabled this agenda. We know that these cuts to health care will hurt us all and cost us more in the long run. Our healthcare providers have been telling us for months, when people lose coverage, when they lose their insurance and healthcare becomes more expensive, everyone loses. Our communities lose. In the after effects of the big ugly bill, we know that hospitals have to provide more uncompensated care as a result, making it even tougher, especially in our rural areas. Dr. Horowitz, in your testimony, you note that nonprofit hospitals are more likely to operate at low financial margins. How do you expect these hospitals will respond to the healthcare cuts included in the Republican reconciliation bill and the increased amount of uncompensated care they will inevitably end up having to deliver?
With rising rates of uninsurance, somebody is going to have to pay for the care that people will need. And nonprofit hospitals, even if they did spend all of their profits that they could possibly earn on the uninsured in America, they could not cover the need.
Thank you. I think it's valuable to note that I also want to make sure that we ensure nonprofit hospitals are adhering to the requirements of the law. And during a hearing on the same topic last Congress, I discussed the Affordable Care Act's requirement for the IRS to audit every tax-exempt hospital at least once every 3 years to make sure that they provide sufficient community benefit. At the time, the GAO, the Government Accountability Office, noted that the IRS has not revoked a hospital tax-exempt status for failing to provide sufficient community benefits in the last 10 years. The Affordable Care Act made this a requirement because we knew it was important to ensure that hospitals were provided this needed benefit. However, over the last several years, Republicans have continually chipped away at funding for the IRS. And so it's ironic that they're concerned about whether these hospitals should have tax-exempt status while actively gutting the agency and the work that would actually go into place to make sure we're doing these audits and we're enforcing any changes. So Dr. Horowitz, again, how can Congress work to ensure that nonprofit hospitals know what's expected of them to maintain their tax exemption status without putting these hospitals at financial risk at a time when our healthcare system is already under attack?
You know, we could continue to invest in the IRS while making sure we're focusing on all the benefits that nonprofit hospitals provide. An IRS that focused on major medical services would be very helpful to the system and would help channel nonprofit hospitals to do the very important work that they need to do. But we need staff, and we need enough staff in the exempt organizations division to be able to issue guidance to help the hospitals do their jobs.
Critically important. And just again, we have so many important hospitals and definitely nonprofit hospitals providing important services to our communities in rural areas as well, areas that are already feeling under attack from the big ugly bill that was passed and putting them at financial risk. And I hope we're focused on making sure our communities have access to great care. So thank you very much. I appreciate your testimony. I yield back, Mr. Chairman.
Thank you. Mr. Young.
Thank you, Chairman Schweikert, for holding this hearing today, and to our witnesses for being here. Hospitals play a critical role in providing health care in our communities. Nonprofit hospitals' tax-exempt status allows them to invest more resources in improving the access and quality of care for individuals in our communities. Indiana has some strong examples of hospitals that are using their tax-exempt status to expand care for some of the most vulnerable individuals and communities. My district has several rural communities that lack access to some of the most basic healthcare services, and our tax-exempt hospitals certainly help fill that gap. For example, St. Joseph Health System uses some of its funds they save through their tax-exempt status to operate a mobile medical unit to help increase access to preventative care across my district. tax-exempt hospitals are subject to various reporting requirements in order to maintain their tax-exempt status. Dr. Whaley, in addition to certain legal requirements and the community benefit standard, I understand that tax-exempt hospitals are also required to file Form 990s for IRS review. This form requires nonprofit hospitals to report a lot of generic information about employees, revenue, assets, tax compliance, but tax-exempt hospitals are also required to include what is called Schedule H, which is used to collect information on activities and policies of hospitals as well as community benefits provided by the hospital during that specific tax year. In your opinion, are the current reporting requirements for nonprofit hospitals sufficient to ensure that nonprofit hospitals are providing real community benefits and operating within their tax-exempt status?
Thank you for the question. Indiana in particular is a market that has, I think especially at the state, employer, and community level, focused lots on hospital prices and hospital markets in the last several years. In regards to Schedule H, I don't think the current requirements are adequate. For example, many hospitals are parts of large conglomerates and mega systems, which often report a Schedule H at the system level, which does not allow for auditors, researchers, and policymakers to understand community benefit reporting at the individual hospital level.
Got it. And are there other pieces of information that you believe nonprofit hospitals should be required to report to the IRS?
In addition to reporting Schedule H's for individual hospitals, the current requirements for Schedule H reporting are often quite vague, and additional reporting requirements for Schedule H and detail on individual line item spending for Schedule H could allow for a more further detailed auditing and accounting of community benefit spending.
All right, thank you. And Mr. Hild, it should come as no surprise that given the massive value of nonprofit hospitals' tax exemption, some nonprofit hospitals choose to spend money in various ways. We have discussed the spending on real estate, stadium rights specifically, but I also understand that tens of millions of dollars are spent on advertising every year. That ultimately raises, of course, questions about why they chose to do this and whether advertising and marketing spending might be going on. While it certainly makes sense for some hospitals to spend money on advertising and marketing, of course, at the end of the day, nonprofit hospitals certainly want to make sure that patients know where and how to utilize their services. Is there an amount or type of advertising or marketing spending that seems unnecessary or frivolous to you? And if so, can you provide some examples?
Yeah, that's a great question, member. And I agree that there certainly are instances where you'd want a hospital system to be able to advertise specific services to a community to make sure that they're aware of those specific services and how to access them. What I would say is an egregious abuse of their tax-exempt status is spending large amounts of money simply on brand ID, on superfluous Super Bowl ads like we saw from NYU Langone, where they spent ostensibly $8 million to simply promote their brand. I think most people in New York in that area already know where to go to the hospital, and if they're sick, to go there. Most people don't need to be told that via very expensive Super Bowl advertising. So I think when you have a situation where it's simply a hospital system polishing their own brand, that is a waste of money and an abuse of the tax-exempt status.
Thank you. Nonprofit hospitals are an important part of our healthcare system, and in some cases, the patient's only way to access care. We need to make sure that nonprofit hospitals that use the program responsibly are protected, while hospitals abusing the system are held accountable. Thank you, Mr. Chairman, and I yield back.
Thank you. Because I've lost Mr. Swazi for a moment, we're going to actually, under the committee rules, we're going to go to 2-1. Mr. Miller.
Thank you, Mr. Chairman, and thank you to all our witnesses for being here today. Maintaining the highest quality standards of care in our nation's hospital is a key priority. As has been discussed, nonprofit hospitals are deemed to be those operated for charitable purposes with a mission to serve the public good, providing community benefits. Nearly half of American hospitals are nonprofits, aimed at advancing the health of patients through charitable and community care, many providing innovative breakthroughs in treatment for their communities and the nation at large. In tandem, transparency of care is a foundational mission for our nation's hospitals and health systems. I understand hospitals in Northeast Ohio provided around $2 billion in community benefits in the year of 23, according to the most recent analysis we have. Such key efforts of others include a diabetes center in Cleveland's economically stressed areas, empowering public safety medics with life-saving training, groundbreaking cancer screening for first responders, supporting more than 20,000 food insecure children, and funding the Lead Safe Cleveland Coalition. A recent report also noted, compared to other states, Ohio hospitals spent more on community health improvement services, a positive sign that they're investing in upstream and unmet health needs. The mission of all hospitals and health systems, regardless of size and type of ownership, is to care for their patients and communities. Likewise, sound, accountable, and transparent use of taxpayer funds is paramount to ensure the highest levels of integrity in patient care. To Dr. Chris Whaley. Dr. Whaley, you noted in your testimony nonprofit hospitals play a critical role in providing patient care. As you know, nonprofit hospitals carry a community service mission, and current statutory requirements mandate that hospitals must maintain a publicly available financial assistance program and conduct community health needs assessments to identify key health concerns, soliciting input from underserved, low-income, and marginalized communities. How can these benchmarks ensure the highest levels of transparency and integrity in community care in our country, and how can transparency be strengthened to demonstrate the full breadth and accountability of nonprofit, charitable, and community care?
Thank you for the question. And related to my previous response, I think there could be increased transparency on spending on each of those components so that we can essentially compare what is the value of tax exemption with the value of community benefits. I would also note that while many hospitals do provide, nonprofit hospitals do provide community benefits, many of the hospitals with the highest prices in the country are large nonprofit hospital systems. And so we pay for many of those services through the backs of patients.
Thank you for that, Doctor. Dr. Bai, note in your testimony, nonprofit hospitals face significant operational challenges, including declining collection rates on medical bills and low reimbursement rates for many patients. Many nonprofit health providers serve a large share of Medicaid patients. One major hospital system in my region delivers more than 50% of its care to Medicaid recipients. They also treat a growing number of the Medicare patients despite the program's low reimbursement rates, as well as the uninsured. Please share your thoughts on how Congress can strengthen the viability of the healthcare system for patients, providers, and American taxpayers.
Thank you. I believe the root cause for the unaffordability of hospital care is the high price. It comes from the high operating cost of the hospitals. If you look around other markets, technology always brings lower costs, but that's not happening in healthcare. Why? It's because of lack of competition. There's an example. One private equity firm purchased a hospital, especially a nonprofit hospital. They cut the admin staff by 1/3 while still maintaining the quality of care. This is coming from a Journal of Financial Economics study looking at more than 1,000 deals. That's a conclusion. So that means at least there are some redundancy in the cost structure of many of our nonprofit hospitals. Without competition, why would any hospital CEO cut cost? There's no reason, right? So they want to become more lean in operation only when there is external pressure. So I believe once we have enough competition in the market, they will try to make their operation more efficient. That will directly lead to a lower cost of care. That is true affordability and access for our patients.
I'm smiling. Thank you. That was a very well and thought out answer, and I could not agree more with what you had just laid out. I won't name any hospitals within my district, but some of them are undergoing some of the same things and seeing how we can consolidate and do better. So I just want to say thank you for that answer moving forward. Mr. Chairman, I yield back.
Mr. Chairman, on behalf of my colleague, Mr. Panetta, I would like to ask unanimous consent to include in the record of this hearing the 2024 annual report of the Sutter Health, which serves his district.
Without objection.
Thank you very much.
Mr. Swazi?
Thank you, Mr. Chairman. I'd first like to start by associating myself with the remarks of Congresswoman Malliotakis from my state of New York, where all of our hospitals are required by law to be not-for-profit. And she was sounded in her remarks very praiseworthy of the not-for-profit hospitals in her district as far as the care they provide, the community benefits they provide, and the employment they provide. So I want to associate myself with her remarks. I feel the exact same way about the not-for-profit hospitals in my district as well, which is along the North Shore of Long Island and Northeast Queens in New York. So I want to thank the witnesses also for their time here today. I really appreciate you taking the time to be here with us and share your backgrounds with us. I want to ask you first, you're all aware that people in America are very concerned about their health care costs, right? Mr. Hild, you're nodding your head, right? You're aware of that? Dr. Goldfarb, you're aware of that? Dr. Bai, Dr. Whaley, Dr. Horowitz? And people's health insurance premiums are really high. And that's one of the things that they're really worried about is their health insurance premiums. And if you ask the American people, what are the issues you're most concerned about in America today, most people say the number one thing is affordability and the cost of living. You know, that's tied into the economy as well. But that's the number one concern people have. Now, I don't know if you're aware, but currently many insurance policies in America are subsidized by a premium tax credit that makes the Affordable Care Act insurance more affordable for people, and that premium expires on December 31st of this year. Are you aware of that, Mr. Hild? Are you aware of that, Dr. Goldfarb? Dr. Bai, are you aware of that? Yes? Dr. Whaley? Dr. Horowitz? Okay, so there are some of us, Democrats and Republicans, there are 11 Republicans and 6 Democrats, of which I'm one of them, are saying we should extend the premium health care tax credits at least for a year. I actually think it should be more than that, as part of this debate that we're doing now about closing down the government. Because if we let these premium tax credits expire, then people's insurance rates are going to go through the roof. So, and it's not just me, you know, Democrats versus Republicans. I have Senator Tom Tillis said in early September, he said, I think it's a bad policy and bad politics to let these premium tax credits expire. And the co-sponsor of this bill with me, Congresswoman Kiggins, said that there are 33,000 people in her district that rely on this tax credit to make their monthly health insurance premiums more affordable. If Congress fails to act, those same Virginians will soon face shocking cost increases that could put essential health care coverage out of reach. We can't pull the rug out from under hardworking families. We must give Americans more time to plan. So and then she talks about how much everybody's health insurance premiums would go up. And then Congressman Fitzpatrick says the same type of thing, letting these subsidies expire without a plan would put health care coverage out of reach for millions of families in my community and across the country. This bipartisan targeted extension will prevent disruption, protect access. And it goes on and on with other members talking about how devastating this would be in their community. So based upon what you're hearing, do you think it would be a good idea for us at least extend these health care premiums for at least a year? I think it should be longer than that, to at least figure out a plan for us to how to deal with this so people's health insurance premiums don't go up. What do you think, Mr. Hild? Mr. Hild.
That's sort of out of the purview of what we issued our report on, but I would say that to your point about affordability and price control, I completely agree that the average person is focused on that, and that's why we think it's so important that hospitals focus on just the provision of health care and cut out any extraneous costs so that they can pass that savings on to the consumer. And I additionally say...
You know what would happen is a lot of people, if they don't have insurance because they can't afford it, they're going to show up in the emergency rooms of these hospitals. It's going to cause the cost to skyrocket. So let me ask Dr. Goldfarb, what do you think? Do we think we should let these premium tax credits continue?
Well, as I said before, I'm no expert on these issues. I must tell you, though, that I've been in meetings like this for 35 years. And the problem has been the rising and soon unaffordable cost of American health care. You people in Congress, you need to fix the health care system. And this is not about just changing insurance premiums. This is about a fundamental reform that must go on, and I look very forward to seeing that happen.
I think that's an excellent point that you're making, Dr. Goldfarb, but in the meanwhile, we don't want to see these people all lose their insurance. Dr. Bai, do you have a position on this?
Yes, I do. I don't think we should extend. Because the
Okay.
insurance is not the same as coverage. We have seen many people covered, but then face medical bills. Second,
So
the
these
fundamental
people,
reason.
so you're okay with these people losing their insurance?
No, the fundamental reason for the high premium is because ACA regulations prevent insurance companies.
No, but we can't
from-
fix that between now and December 31st, can we?
If we have the money to spend, let's fund the patients. Let them control the money. Then they make the choice. That will totally transform our healthcare market for everybody's benefit.
Very good, thank you. Dr. Whaley?
In many states, insurance premiums are expected to rise 20 to 30%, which I think is a
No, some people are saying 50 to 200%.
substantial shock for many patients. Having some sort of smoothing would probably be beneficial, but I think it's also important to recognize that rising hospital prices are a key driver of why insurance premiums are
Thank you so much. Okay, I'm out of time. Can Ms. Horowitz answer, or should I stop? Ms. Horowitz, you want to answer that?
Just make it.
Yep, insurance prices are going through the roof, and now is not the time to increase insurance costs even more. So if the tax credits are allowed to expire, we're going to see even more people be uninsured.
All right, Mr. Bean.
Thank you very much, Mr. Chairman. A very good afternoon, and good afternoon, Ways and Means. And to our panelists, welcome. We're glad to have you here. If you're just tuning in, if you just turned on C-SPAN, we're in Ways and Means, and we're talking about tax-exempt status for hospitals. Now, we know all hospitals are different, and not all hospitals are like every other hospital, but we're trying to determine whether taxpayers are getting a good deal by Congress granting tax-exempt status to certain hospitals. There's always been a kind of an agreement that with tax-exempt status, we'll get more. We'll get more as these hospitals will give more in community care and investing back in the community than the amount of the tax-exempt status. But here's the numbers. Here's the numbers. It's no secret the value of tax exemption for nonprofit hospitals has ballooned in recent years, rising from $19 billion in 2011 all the way up to $28 billion in 2020. What some may not know is that during this same time period, the tax exemption value at $28 billion in 2020, we're only getting $16 billion back in charity care. So the numbers are already underwater. So Dr. Bai, does the difference in the value of the tax exemption for nonprofit hospitals and the amount spent on charity care suggest, do these hospitals